Welcome to the Our Forever Smiles podcast, a podcast created to support mothers of children who were born with clefts and those who love them. I'm your host, Laura Arroyo. Hello, and welcome back to the Our Forever Smiles podcast with Laura Arroyo. As you can see, we have been releasing our ACPA annual meeting podcast episodes. So, staying along the same theme, we will continue to be speaking with specialists, SLPs, geneticists, surgeons, everyone, all professionals that are along the cleft journey with us, moms and parents. And so I am really excited today to speak with Dr. Manlove. We are so excited to have her on the podcast today.
I'm so excited to be here. Thank you so much for the invitation.
So as I've shared a lot on the podcast, I am a UNC patient. Well, I guess I am a patient, or maybe Giselle is the patient.
I don't know. Sometimes I feel like the whole family is a part of the patient team, right? You have the surgical and the healthcare team, and then we have the family team. So you're definitely part.
So how long have you been at UNC?
I started at UNC in August of 2024. So it's been about 9 months.
Okay, so you're like brand new.
I'm brand new.
Oh, okay. So you just basically just started. How do you like it?
I love it. Absolutely love it. It was a big move. I came from a much smaller institution in Central Illinois, Carl Foundation Hospital, where I was there for 8 years, and I ran the Cleft and Craniofacial team there. But it was a much smaller team, so I'm really excited to be at UNC, where there's so many disciplines and there's additional surgeons to collaborate with, and it's a university setting. So there's just a lot more research, and the team's huge, and it's such a great team. It's a wonderful team.
Yes, I've always wondered that, because you'll probably laugh at this, but so my daughter's surgeon was Dr. Wood before she left UNC, and Dr. Leeper placed her ear tubes during her palate repair. And so I was speaking with another parent, and I may have misinformed her. Well, I know I misinformed her now, but she told me that she was trying to make the hard decision of deciding between Duke and UNC. And she told me that she was meeting with Dr. Leeper, and I told her, well, that doesn't really make sense, because why would you be meeting with the ENT? They don't do like palate surgery. So I just got myself confused and everyone all confused.
It is so confusing though, and I think, there's surgeons. So cleft and craniofacial surgery is done by plastic surgeons, of course, and otolaryngologists, of course, and oral maxillofacial surgeons, of course. So we all do it, and we're all fellowship trained to perform most, if not all, of the cleft and craniofacial surgeries, which is pretty awesome.
Yeah, that's so interesting. So you get your specialty and you're basically trained in cleft and craniofacial care. Is that how it works?
Exactly. So you have to submit essentially like a case log to be for the hospital to grant you privileges to do the surgeries.
Okay, so what made you want to do that? It's more school, more things.
It is, but it's a long road, but there's nothing I'd rather do. I feel like I love my career. I love oral maxillofacial surgery. It's such a unique profession, but then to be able to do cleft and craniofacial and pediatric oral maxillofacial surgery on top of it is just so fantastic. I love being able to work with families from prenatal, from before the baby's even born and they have a prenatal diagnosis, or at the time of birth when they didn't realize that they were going to have a baby with a craniofacial anomaly, but then work with them from that moment to adulthood and beyond. It's amazing to be able to interact with the families and watch the kids grow and kind of be with them every step of the way.
Do you see patients beyond 18?
So yeah, for me, I do. I'll treat all age ranges and do cleft and craniofacial surgery. I've treated many adults with craniofacial anomalies, whether it's revision surgery or whether it is primaries that they just haven't had repaired for whatever reason. I actually have one coming up this summer. I'm doing a bone graft on a patient who just never had it done. They're in their 30s or 40s. So, yeah, I do treat adults. So that's one of the benefits I think of being oral maxillofacial surgery, cleft craniofacial. I don't just stop at pediatric.
Yeah, that's so interesting. Another thing that I kind of was confused about or didn't quite fully understand is that not all surgeons do all of the surgeries that are required along the cleft journey. So some surgeons just do lip and palate, while others do like VPI surgeries and bone grafts and that type of thing.
I am well at Carl, right? So where I was the primary surgeon. So I literally did everything from prenatal to the primary lip, the primary palate, the speech surgery, if it was necessary, bone grafting, and jaw surgery. Basically, saw them through it all. Now that I'm at UNC, because there's 4 surgeons, we all do some overlapping, and we all are trying to kind of, I think, find our niche and see how we're going to best take care of these patients and their families.
Hi, I am so sorry to interrupt the show, but I just want to tell you about today's sponsor. Today's show sponsor is Sienna Darn Media Integrated Marketing Agency. Sienna Darn Media is more than just a marketing agency, they are your partners in progress. Their mission is simple to alleviate marketing bandwidth, allowing creative business owners to focus on what they set out to do create. Sienna Dawn Media empowers creatives to thrive without the burden of managing their own social media and marketing campaigns. Visit siennadawnmedia.com. Yes, I love that. So, what do you think is your favorite surgery?
Oh my gosh, my favorite surgery. So I mean, I have 2 favorite surgeries for sure. I mean, I love primary lip repair. There's something magical um, about doing or performing a primary lip repair and doing that surgery and providing that service for the family and following them. I also love mandibular distraction osteogenesis. So when babies are born with very small mandibles, and not all babies with small mandibles need distraction, but if they do, doing that surgery because you're literally changing their life, you're changing their airway, you're avoiding a tracheostomy. So it's just a very rewarding surgery. And again, it's a very kind of intimate relationship that you have with the family because you're with them multiple times a day and with their baby multiple times a day. I don't know, there's something about, I think, walking these families through kind of each step that is why I love my job so much. Yeah, it's definitely one of my favorites.
Yes, I find that a lot of surgeons say that lip repair is one of their favorites too. I've also heard people say jaw surgery as well is another favorite.
And jaw surgery is another one. I mean, I love doing orthodontic surgery, jaw surgery, and it's the same, very much the same, because you're providing like an immediate change to these patients that they see, and the aesthetic functional change that they have after surgery. You change your life, and I think kind of like those life changing moments are the things that really kind of ring true to me.
I imagine that it's like so rewarding to kind of like see, I don't know, like the work that you've done, like being able to be with a family and follow that family and get to know them. And then of course you can kind of like see the magic in those results. So my daughter Giselle was born with a surprise cleft palate. And so when she was first born, there was some kind of like hinting around that she possibly could have PRS. And so, of course, I mean, no one blatantly said that. They were just kind of looking at her and they said, like, oh, she has a small jaw. And so, naturally, right, I went home and I Googled and I found out that, I guess they were thinking that Giselle had Pierre Robin's sequence. And so with that, I know that there are the treatment or traditional treatment that is available for PRS is those pins that you have to put in the jaw. And so when you're referring, I guess, to the mandible, is that what you mean?
Yeah. So if the baby's born with a small jaw, what happens is the tongue essentially doesn't have enough room. The tongue is sitting in the back of the throat and it's occluding the airway. And a lot of times it's also sitting in the roof of the mouth, which is why a lot of these babies do have a cleft palate. Um, but the surgery that's done is a distraction. So these devices go into the jaw, the bone is cut, and the devices go in and You turn the devices multiple times a day, and it slowly, we're talking like less than a millimeter, slowly separates the bone. And as the bone separates, it fills with blood. The blood has the bone cells that come in, and then it eventually hardens and forms a bone. I know it sounds so grotesque, and it sounds like torture, right? And that's what I do. I always talk to the family and talk to the nurses that are taking care of these babies. The babies are incredible. They're incredible humans, and their ability to overcome a surgery like that, and the family is all about educating, and they do so well, surprisingly well. I know it sounds, like I said, it sounds like torture, but it works, and the babies do so well, and they don't even mind when you're turning the distraction arms. It doesn't even phase them. It's pretty amazing. But I'm glad your baby didn't have to have it. As a surgeon, I never wish surgery upon anybody. So I'm glad, obviously, less is more. But if it's necessary, it it's a life changing surgery for sure.
So I know you're not a geneticist, but I guess I've just always been curious. Giselle did have a genetic panel done, genetic testing done, and it came back that her cleft was isolated. Can they test for PRS through genetic testing, or how does that work? I never really got like a solid answer on that. If she has PRS or not.
Sure. So Puraban or Raban sequence is a phenotype. It's not a genetic diagnosis. So it's a triad of findings, um, but not necessarily genetic related, if that makes sense. But the cleft palate, an isolated cleft palate, is more likely to have a genetic component, which is why they often will genetic test babies born with an isolated cleft palate. But Purobana in and of itself is not a genetic diagnosis.
Okay, so it's just like a series of traits.
Mm-hmm. Yes. Yeah. So small mandible, and a tongue that flops back, the glossoptosis obstruction. Could a mild, and it's also a spectrum, right? So there's not like a cutoff really. It's a spectrum. So you could have very mild, where maybe the mandible is small, but not so small that it obstructed her ability to breathe and to feed and to grow.
Well, so now you got me thinking, like, maybe she did have PRS. We just didn't know.
But it also, like, it doesn't really change anything, which is good too. But yeah, she may have or may have, yes.
So you mentioned something really cool. So UNC now has 4 surgeons. So does that mean that parents or people that are newly diagnosed with cleft can come and like interview you all, or how does that process work at UNC?
Yeah, so we're working on just referral kind of patterns. So some patients will be referred directly to surgeons. So that is, if somebody's referred to a surgeon, then oftentimes they'll just, they'll see that surgeon. We also have patients who are referred to the Craniofacial Center, and those are distributed just evenly around the team. So that right now is kind of the method of patients who are joining our team.
So you could potentially just like market yourself and then receive referrals that way, right?
Yeah, it's an interesting kind of phenomenon, but I think, the goal is to have a team-centric approach. So we want our team to function as a team and to provide care for these patients. So it's all about patients first, and patients have the ability to see and to have treatment with us at UNC, or honestly anywhere in the US. They have the ability to make their choice for themselves.
Can you talk a little bit about the VPI surgery? Do you do that surgery?
For VPI surgery, so, thankfully at Carl, we didn't have a ton of patients who required VPI surgery, but I did do speech surgery. Now that I'm at UNC, I feel like it's not one of my favorite surgeries. Can I do it? I can, but I'm sending mine to Dr. Leeper, to our ear, nose, and throat doctor.
Do you feel like now that palate repair surgeries are sort of in proving or are just better that maybe VPI surgery isn't necessarily as required as much as it used to be?
I think it comes down there's 2 things. So it could be, it definitely has to do with the repair and the way the repair is done, but it also has to do with anatomy. So some patients have just a shorter palate or a really deep pharynx. So, the soft palate has to be able to touch the posterior pharyngeal wall in order to have the air come out of the mouth versus out of the nose. So if the palate is short or if the pharynx is deep, then the air is coming out the nose. We'll monitor these patients. Speech therapy is great for articulation disorders, but you can't fix VPI with speech therapy alone. I think also speech therapy is very important because when you're doing surgery on a cleft, speech surgery is essentially physical therapy for the palate, right? Is how I look at it. So being able to speak and having therapy to move those muscles is so important to be able to basically rehabilitate them and make sure they're working properly.
So, why do palate repairs fail?
Mm. So, I mean, there can be a lot of different reasons why palate repairs fail. Let's see. So it can be, wide palates, of course, are much more challenging than narrow palates. It can be if the palate is closed under tension. You want a tension-free closure when the palate is repaired, and it's a layered closure as well. So the nasal mucosa is reconstructed and closed, the muscles are closed, and then the oral mucosa is closed. So at the hard palate level, it's a 2-layer closure, and then at the posterior aspect where the soft palate is, it's a 3-layered closure, and all of it should be tension-free. So it just requires a meticulous dissection, freeing up all the tissues so that it can advance and close. So if it's not closed, if it's closed under tension, obviously, any wound under tension is just going to have a little bit more contracture, a little bit more scar formation, and it could potentially break down. But there's lots of other factors too, right? I feel like if the baby is sick and they're having a lot of nasal drainage and there's a lot of bacteria and mucus in the nose that's sitting on top of the incision, I feel like that can cause them to break down. So I always, 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 I know it's so hard when you have a planned surgery, but the baby's sick, it really is worth waiting. You know, I, thankfully, I haven't seen a lot of palate failures per se. I mean, there's so many other reasons, right? But I think surgical technique is definitely a big part of it. Probably at least 60%, maybe even 75%. And then the home care is really important too. When we give instructions on how to care for the baby after surgery, we're not as surgeons, we're not doing it to be frustrating or mean or annoying. We're doing it to try to provide the best outcome long run, because really, if you really have one shot to have a really good palate repair. To go back in and to fix a fistula is doable, but hopefully it's very few and far between.
Yeah. Do you tell your families to wean from the bottle?
So no, I feel like, yeah, I really want to do a study on this, because no, I'm very simple. I'm very, very simple. So let's see, palate repair is usually around 10 to 13 months of age, depending on the size of the baby and any other medical comorbidities. But no, if they're feeding with I love the Dr. Brown. I don't know if I'm allowed to promote bottles. I love the Dr. Brown specialty feeder with the valve. So I feel like most of my babies have used that. And if I just have them stay on it, the valve's wonderful, right? Because you don't have to have any suction. All you have to do is compress the nipple and the milk comes out. So after palate repaired, straight back to the bottle. I said, why don't no stress, right? It's so stressful to have a baby with an anomaly, and then to have a baby that has to have surgery is so stressful. So like the last thing you need is stress on feeding. No, like just do what they're used to. I do Dr. Brown specialty feeder after surgery, stage 2 baby food. So no solids really, just like very pureed things or blended foods for a couple weeks until I know the palate is healed, and then life returns to normal. I don't do no-nos.
No, no nos? Oh my goodness. Well, I'll just go ahead and confess. I took them off. I was so concerned about Giselle because she sucks her thumb. And so that was like my main thing that I was worried that she was going to try to suck hurt them. But I took them off, and surprisingly, she didn't want anything to do with her them.
I that's my thing. I was like, honestly, like if it's uncomfortable, they're not going to do it. And a lot of times, I don't know. I haven't had any issues with the bottle or with no. So, um, my outcomes have been great.
Yes, it was the same with the bottle as well. I was stressed out about weaning from the bottle, and I tried to feed her from the bottle once we were approved to use it, and she didn't want anything to do with that either. So what I try to tell parents too is like, don't stress too much about it because you don't know what your baby's going to want after repair anyway. They may not be in the mood for the things that you think that they're going to be in the mood for.
Right. And it's so unpredictable, right? Like I've had babies who I feel like they're refusing. It's like they're so mad that they had to have surgery that they refuse to eat with a bottle. They refuse to do anything. So yes, I've had a handful that have had to syringe feed. I've had some that were like, now they don't want a bottle. Now they want as a cup. I was like, well, then give them a cup. And then I've had, I'd say most just go straight back to the bottle and they don't have any problems at all.
So, another big question that I see in a lot of the groups or people ask me directly is sometimes after palate repair, moms will say that their baby's breath smells awful. I know it's such a strange question, but I guess at one point, do you like call the hospital for like bad or smelly breath? I think that they think it's like an infection or something.
That's a great question. Um, because as surgeons, we only see them in these snippets in time. So these are no, I've never had this. Nobody's ever told me that their baby's breath smells so bad. But it's probably the sutures that retain some of the food and some of the milk formula. So they probably just get really a lot of what I use at least is a braided stitch. So they tend to retain some of that debris. It can be hard to wash out or rinse out after feeding unless you give them maybe some water. But I don't it's very unlikely I get an infection. I've never actually seen a palate or a lip for that matter get infected after surgery.
So, it's a common thing.
Hmm. Yeah, so maybe like my advice would be a little sip of water, a little rinse afterward.
And in these groups, it's like, people from all over the world. So sometimes people are like, "Did you give them mouthwash?" And I'm like, "Oh, no, please don't. Just do your normal thing. Just water or milk. Just leave it alone."
Because you can't really brush it. You're not gonna brush the incision.
So when should babies expect to develop suction after palate repair? So I'll give you my situation. So Giselle had surgery in May, and she had suction by July, which really surprised me. But so many moms comment on the groups, and they want to know like when are they able to get their baby to drink from a straw?
That's a good question. Probably, yeah, anywhere between like 3 to 6 to 12 months after surgery. I think it takes time and it depends not only on their desire, if you will, right? Children are so finicky and they're so funny and they have their own kind of timeline in mind, how much you work with them, and also, is there anything else going on? So somebody with poor motor control is going to take longer than somebody who has like normal or advanced motor control. So, but I'm fine after a couple months. Like once everything's healed, go for it. I'm trying to think back to my own children and when they started drinking from a straw. I feel like they were, like they were at least 18 months to 2 years, I think, before they started using a straw. Obviously, they could form the suction because they either breastfed or drink from a bottle, but drinking from a straw is like special.
Yeah, that's so interesting because I never thought about that. I guess kids that are born without a cleft also have to develop the skill of drinking from a straw. It never occurred to me that like, yeah, I guess we're always so stuck on the fact that they weren't able to breastfeed or that they had specialty bottles that, we just don't think about the normal, um, I guess, baby protocol.
I guess the 360 cup is it 360? Yeah, the 360 cup requires a little bit of suction, but again, I tell them don't stress, like they'll get there. Doesn't matter if it's at 18 months or 2 years or 2.5 years. As long as they're healthy and having fun and healing well, just let them be. Let them be kids.
Yeah. So what do you think is the most challenging thing for parents?
Yes. I think unknown. You the unknown is always so scary, whether especially when it comes to your child, right? Like, you want to make sure everything is perfect and you have this vision. I think that is the hardest thing. What your vision is and trying to match that vision and unknown about what's going to happen from the minute you hear or you find out that your baby has an anomaly, whether it's craniofacial or something else, right? It doesn't matter. Just that unknown. It's so hard.
Yeah, I think that is one of the most challenging things. It is the unknown. You like don't know what to ask, and you come into the hospital with a 4-week-old baby, and you're like, "Are they going to need speech therapy?" And I think, I think the surgeons are in a tough spot because it's like, I don't know, or yes, but you don't want to say yes because you don't know, and so it just is this balance of you don't want to overwhelm parents, but also you want to provide them with the information that they need. So
We'll see. And that's what I say. Like, I try to educate. So I try to educate as much as I can. And I educate from day one, whenever that day is, until as much as they want. And I repeat over and over, every visit is probably a lot of the same thing. But I think it's really important to just educate and know that we're with them and just try to focus, right? One step at a time, one day at a time. Don't think about 10 years from now and will they need X, Y, or Z, because I can't predict. I don't have a crystal ball. I have no idea. So let's just focus on now. Let's focus on what we can control and what we can do. And, we'll be with you every step of the way.
So, what has all of your work taught you about life?
Yeah, life in general. Oh my gosh, this is a loaded question. I think I was just talking to one of my colleagues today and I said, I think my mantra that kind of keeps me going is be good to people, be a good person, do good work, and good things will happen. And that's kind of how I feel like I live my life. I want to, first and foremost, like, just be a good person. Treat people how you want to be treated, treat people with respect, do good work. Obviously, as a surgeon, I'm very self-critical. I'm always feel like sometimes I think as surgeons we're probably more critical than most. Um, want everything to be perfect because we also have visions, of how we want repairs to look and how we want function and what our expectations are very, very high. We set such high standards for ourselves. Um, so do good work. But then I think at the end of the day, good things will happen.
I just want to thank you so much for being on the podcast, Dr. Manlove. Yes, Giselle will be in office. So you will see her soon. Hey everyone, it's Laura here. I'm popping in today because I need your help. If Our Forever Smiles has ever helped you, if you've learned something new, felt less alone, or found hope through this podcast, then I'm asking you to help keep it going. Creating this podcast, sharing stories, and building a space where Cleft families feel seen and supported is something that I pour my heart into. But the truth is, I cannot do it alone. If we want to reach more families and provide even more resources, we need your support. So I thought of a creative way to do this. For just $2 a month, you can help ensure this podcast keeps going strong. For $5 a month, you'll unlock exclusive Moms in Real Life content, real unfiltered conversations about motherhood and career and everything in between. And then for $10 a month, you can get everything plus exclusive merch to show your support. If this podcast has helped you and you want to see it grow to help other families that are probably facing the very same challenges that you are facing right now, please consider supporting us today. Every dollar goes toward making a difference for Cleft families just like yours. And right now, we'll be using the funds to elevate the show for production. So we'll be able to add more video and just get new equipment. And as soon as this community is established and we're able to do more, we definitely plan to go beyond the scope of just this community. We want to be able to support scholarships for new craniofacial surgeons. We want to be able to support global surgeries and just really spread our efforts to continue to make an impact in our community. I just want to thank you in advance, and I'm just so grateful that you all are able to support me and support this community here. And it's definitely something that I'm really looking forward to. The link is in the show notes, and I just want to do a shameless plug here. The Moms in Real Life podcast is so cool, so candid, and yeah, it's definitely something that you'll want to check out. Thank you all again.